Addiction and mental health challenges deeply affect our society at every level, but there is hope that people can get into recovery and live healthy, fulfilling lives. In our town hall, Addiction and Mental Health, Finding the Road to Recovery, we bring together healthcare experts, community leaders, and individuals in recovery to discuss the realities of addiction and the promise of novel treatments. Join us next as we help break the stigma and highlight hope for individuals, families, and communities.
Thank you to the Eunice Joyce Gardner Charitable Foundation for its leadership support of the Health Channel.
Welcome to Addiction and Mental Health, Finding the Road to Recovery. I'm Carla Hill, and thanks for joining us. We have all heard about drug addiction, but here is an eye-opening statistic that highlights just how serious the problem is. More than 130 people die every day from opioid-related drug overdoses alone. Much of these overdoses are from dangerous synthetic drugs like fentanyl. Now, of course, even one overdose death is too many, but there is some good news. A recent report from the CDC says deaths from drug overdoses are actually down 24% year to year, which equates to more than 70 lives saved every day. So although more has to be done, there are some strategies that seem to be working. Over the next hour, we will take a look at what's working and see what more needs to be done. We have a wonderful panel of experts to help us. First, I'd like to introduce you to Dr. Stephen Lloyd. He's an addiction medicine physician and the director of the West Virginia Office of Drug Control Policy, and he's himself in recovery from an opioid addiction for more than 20 years. Dr. LaToya Lewis is an associate professor at the University of Miami School of Nursing and Health Studies. And Ms. Suzette Fleishmann is a licensed mental health specialist and vice president at the United Way of Broward County. And we also have Dr. Courtney Miller. She's the director of academic affairs and professor of neuroscience at the Herbert Wertheim UF Scripps Institute for Biomedical Innovation and Technology. Thank you all for joining us. So this is such an important topic. We also want to hear from you at home. Email us now with your questions and comments to questions@allhealthtv.com. That's questions@allhealthtv.com. We're going to start with you, Dr. Lloyd. In a recent documentary produced by the Eye On channel, you talked about the evolution of the opioid crisis throughout the 1990s up to the modern day fentanyl epidemic. You made a startling comment about what you call the scariest thing about what's happening with fentanyl. We're going to take a look at that clip now.
What I didn't see coming on was fentanyl. And back 7, 8 years ago, we started seeing fentanyl on the streets in the United States. And what fentanyl is it is a synthetic opioid. It is basically taking the opioid that comes out of a natural poppy plant, altering it chemically by man to make it stronger and longer acting. And it's much more powerful. The scariest part about the fentanyl epidemic is this. Today, you don't have to have an addiction. You don't have to have developed dependence. You can just use one pill and die.
Oh, Dr. Lloyd, that is terrifying, it's troubling, and scary, all wrapped into one. Please comment on what we just saw.
Yeah, thanks, Carla, and thanks for to my friend Jack Namer and the Journey Within for doing that video, because it's so important that people understand what we're talking about. And sometimes when I see the one pill thing, and you don't have to be someone in addiction, it bothers me a little bit, because it shouldn't make a difference. It doesn't make a difference if you do have addiction and you're a long-time user, or it's a one-time thing. But I think the scary thing that people need to understand is that now, you get a hold of the wrong pill one time and you die. Recently, somebody said addiction hasn't changed any in the last 100 years. And that's somebody really that's in my opinion, living underneath a rock. because it has changed dramatically in the drugs that we face. And, I tell people this all the time. If I have addiction myself. If I relapse on alcohol today, I'm 58 and healthy. It'll take 20 years of hard drinking to kill me. But if I relapse on heroin and get a hold of fentanyl, or I think I'm buying a pill off the street that turns out to be not oxycodone but fentanyl, I can die this afternoon. So it's much more desperate now, Carla, and that's the scary thing that I think people need to understand. And these pills that look just like pills that come out of our pharmacy. I mean, it's hard for me to tell the difference, and sometimes I can't tell the difference. They're so good. Wow.
Thank you so much. I want to go to Dr. Lewis. You work with college students, and the concept of this one pill can kill. It has to be something you know firsthand, and it's certainly concerning to the medical community. Share with us what you've been seeing on the campuses and hearing.
So essentially, with the one pill aspect, we're concerned about the students accessing these pills. A lot of times it's regarding stress, anxiety, or another student may introduce them to different medications to help them cope with the college environment. So what we're trying to do is make sure we address the mental health needs of students, but also in regards to patients, our patients are concerned about for pain management if we offer them fentanyl because of what they're hearing in the media. So we're really trying to bridge the gap between future nurses and future providers on their education for their use of other drugs to cope, as well as patients, and encouraging patients to make sure that the medications are being used for the time period that they need it for, and also to provide them education and awareness. So we're really trying to bridge the gap between two communities at the same time who are at risk.
Wow. And Suzette, agencies like the United Way, how are they getting the word out about one pill can kill?
Sure. So we have the Commission on Behavioral Health and Drug Prevention, and through the Commission and our partnerships, we have ad campaigns on TV and radio stations. We have digital ads on social media, posters at convenience stores and billboards where we're getting the word out about one pill can kill. But further than that, we also have grants that for prevention services, for making sure that we're meeting the needs of the community to raise awareness and provide education on how one singular pill can in fact kill. We're also providing free Narcan in the community, at different events and venues, distributing it. And it's really important that people are aware, and that people are aware that there's also Narcan as essentially a first aid for anyone. You never know who may be using substances, maybe that one person that with the one pill that can kill them.
Thank you so much. Thank you. So thankfully, there are medications that have proven to save lives in crisis situations. Check out this video from the National Institute on Drug Abuse.
No time to sit idly by. More and more people are dying of overdose from the likes of heroin, fentanyl, and prescription pain medications like oxycodone and hydrocodone. These are all examples of opioids. Opioids are drugs derived from the opium poppy plant or made in the lab. They can treat pain, cough, and diarrhea. But opioids can also be addictive and even deadly. The number of opioid overdose deaths has escalated more than 400% since the turn of the century, with tens of thousands of lives now being lost every year. But many deaths can be prevented with a life-saving treatment, Naloxone. When given right away, Naloxone can work in minutes to reverse an overdose. Naloxone is safe, has few side effects, and some forms can be administered by friends and family. When is Naloxone used? You can save a life. First, recognize signs of overdose: limp body, pale, clammy face, blue fingernails or lips, vomiting or gurgling sounds, inability to speak or be awakened, slow breathing, or heartbeat. If you see these symptoms, call 911 immediately and consider the use of Naloxone if available. How is Naloxone given? Home preparations include a nasal spray given to someone while they lie on their back, or a device that automatically injects medicine into the thigh. Sometimes more than one dose is needed. The person's breathing also needs to be monitored. If the person stops breathing, consider rescue breaths and CPR if you are trained until first responders arrive.
Very encouraging to know that there's something that we all can do. But let's take a minute to dig a little deeper into what opioids are and how they work. All opioids have a similar effect on the brain, reducing the intensity of pain signals reaching the brain and affecting the brain areas controlling emotion and breathing. Opioids include some prescription pain medications and other drugs like morphine, codeine, and the list goes on. Dr. Miller, I want to come to you. You and your team at the UF Scripps Institute, you study substance abuse disorders and its effect on the brain. Can you talk about brain chemistry and how that's linked to addictions and cravings?
Yeah, absolutely. So we're all familiar with dopamine, I think, at this point. We have dopamine decor to make us happy because it's thought of as a sort of feel-good neurotransmitter in the brain. But the reason that drugs of abuse are so appealing is that they act as sort of a sledgehammer on the dopamine system in the brain. So there's a massive release of that feel-good chemical. And the effect that it has is actually to, over time, rewire the brain completely. And one of the brain regions that's affected is the amygdala, which is this small structure really deep in the brain that's sort of the emotional hub of the brain. And it processes both positive and negative. And so that sort of gets it leads to hyper focus on drugs, and it controls the craving that people experience when they encounter things that have become associated with drugs.
So, Dr. Lloyd, back to you. Talk about the relationship between the brain and addiction and how addiction actually alters the pleasure centers of the brain.
Well, I think Dr. Lewis's description was a very good one. You know, it takes a sledgehammer to the dopamine system. And, you know, I think the thing that people need to realize is that, you know, as far as the brain goes, the part of our brain that's responsible for our will and our desire to live is you know, part of the brain that's hijacked by whatever the chemical is, in this case, opioids. And so when you think about it, think about what you would do to save your own life. And the answer to that is anything. Right? I mean, we are survivalists. We will do whatever it takes to preserve our own life. At the same time, it kind of shuts down executive functioning of the frontal lobe of our brain. And the frontal lobe of our brain is only important if you care about insight or judgment. If you don't care about those two things, then it doesn't matter. So so if you look at kind of the double whammy, I have to have this thing out here or I will die. And then losing the insight and judgment with regards to consequences or results of certain actions that it would take to procure that drug. So I think when you put that together, it shouldn't come as a surprise that somebody with untreated addiction will get a heart valve replacement in the hospital, secondary to injection drug use, and then we don't treat them. How long does it take them to use drugs again when they're discharged? And the answer most of the time is the parking lot of the hospital. And so that shouldn't come as a surprise to anybody, Carla, but it does, because they don't understand these basic foundational concepts of the disease of addiction.
Wow. You know, thank you, Dr. Lloyd, once again. There are some medications that have proven valuable in the treatment of opioid use disorder. Take a look at this video from the CDC.
Opioid use disorder is a chronic but treatable condition. Several medications can help support recovery and improve health by reducing cravings, easing withdrawal symptoms, and even reversing an opioid overdose. These medicines are safe, effective, and save lives. Medications for opioid use disorder can be used alone or as part of a larger treatment plan. Each medication works in a slightly different way, but they all fit into very small cellular structures in the brain called receptors, sort of like a lock and key. Here's a closer look at medications for opioid use disorder and how they work. Naloxone is a medication that can save a life in the event of an opioid overdose. When given right away, naloxone works in minutes to reverse an opioid overdose by kicking the opioids off opioid receptors in the brain. This stops opioids from continuing to cause dangerous effects, like slowing or stopping breathing. There are two forms of naloxone, injectable and nasal sprays. Anyone can carry naloxone. In many areas, these emergency medications are available at pharmacies without a prescription. Lofexidine is a tablet that can be used as needed to ease withdrawal symptoms as someone stops taking opioids and the drugs begin to clear completely from their body. This is a process some people call detoxing. Lofexidine attaches to and activates certain receptors called adrenergic receptors in the brain. This relaxes parts of the nervous system to alleviate the nausea, cramping, and flu-like symptoms associated with opioid withdrawal. Buprenorphine is an opioid medication that attaches to opioid receptors in the brain but activates them only partially. In this way, buprenorphine helps reduce opioid cravings and ease withdrawal symptoms in people with opioid use disorder without producing the same high as other opioids. Buprenorphine is a monthly injection or daily tablet that dissolves under the tongue. Buprenorphine may be combined with the medication Naloxone in a single daily tablet that dissolves under the tongue, or a small film that sticks to the inside of the cheek and dissolves. Another medication, methadone, has been used successfully for more than 40 years to treat opioid use disorder. It comes in a liquid or a tablet and is taken daily at a treatment center. Methadone is an opioid medication with slower and more stable effects than other opioids. This medication doesn't produce a high in people with opioid use disorder. This allows methadone to ease withdrawal symptoms, curb cravings, and support recovery. Naltrexone is a monthly injection used to treat both opioid use disorder and alcohol use disorder. Naltrexone blocks the activity of opioid receptors in the brain, preventing the high associated with these drugs and reducing cravings. Naltrexone does not control withdrawal symptoms and is used after someone stops taking opioids or alcohol and the drugs clear completely from their body. If you or a loved one has an opioid use disorder, talk with a healthcare provider to learn more about how medications can help. For many people with opioid use disorder, medication can make life's activities more doable, whether it's finding time for themselves, doing well at work or school, or reconnecting with the people they love. You can learn more about substance use treatment near you by calling the National Helpline or visiting findtreatment.gov.
I'm watching all of these experts on this panel just shake their head at this video. And I want to go to you, Dr. Lewis, and what are your thoughts about these medication-assisted treatments that are available?
Well, essentially, we need to get over and demystify that any person who has experienced an addiction, we need to give them cold turkey, not do anything, and that's it, and they'll get better miraculously, okay? So what we need to really do is with these opioid addictive treatments, we need to think of the word WOW, which is the withdrawal, addiction, and overdose. How are we addressing medications at each point in time? Similar to how we're addressing basic life support, CPR, we need to think about, at this moment, how can we train lay people to help with just nasal aspects?
If I could jump into that.
Yes, come on
Your
in.
thoughts on, remember when we were kids and everybody had to learn CPR? In preparing for this show, I was wondering myself, would I be able to do this? Would I be able to help someone? Should we start doing like a CPR training for the lay person?
Well, as appropriate.
Oh no, Dr. Lloyd, anyone.
Okay, as appropriate,
Yes,
because
yes.
there's.
I have to agree with him.
Well, I opened the door a little bit. But as individuals, our goal are to save lives, continue research, and see how we can improve the future. And if we can save one life just with the nasal spray.
Yes.
Who hasn't possibly seen a nasal spray, taken a nasal spray? The same way we view epinephrine. Oh, you have a peanut allergy. Let me teach somebody how to put it in there.
Listen, but that, Dr.
Yes.
Lloyd, please, I'd love to hear what you have to say. I think I'm representing the lay people saying, oh my goodness, can I do it?
Yeah.
How do I do it?
Yeah.
You can absolutely do it, Carla, and I'll take an aggressive stance here. I think we need to teach kindergartners through fourth grade how to administer nasal overdose reversal drugs, because a lot of these kids have family members and sometimes mom and dad who are at risk, and the most likely person to find them are their children, and so I think that. I think that everybody ought to understand it. And, the other thing is, I remember when these drugs first came out, when I was working for an entity I will not name, wanted me to have doctors take a training program on administering nasal spray. And I really thought, you have lost your mind. right? That nasal spray. And that's what this is for the most part. I don't use the injectables that much for a lot of reasons. The main one is the needles are triggering to some of my patients. But this training, Carla, should be widely available to everybody. And, to me, there is no age limit. If you have the chance of a parent who may be using, then the child needs to understand how to use something like Narcan, because it will save the parent's life. And so I teach patients and family members how to do this all the time.
Dr. Miller, your thoughts on this conversation about, this training for the lay person?
Yeah, no, I completely agree in terms of it should be widely available. I know it's gotten to the point where they actually have them available in some high schools in LA in vending machines, because they've had such an epidemic of overdose. So they wanted to make it available. And as Dr. Lloyd was saying, it doesn't require special training. It really is, it's a nasal spray, and it was intentionally designed to be easy to use.
Wow.
And so it just needs to be distributed so that it's available when it's needed.
Thank you so much.
Carla,
Suzette, I want to ask you.
I want to interrupt.
Yes, no, Dr. Lloyd, this is what this is about, please.
No, I don't want Dr. Lewis to shoot me on this, but back when, when I first heard of this, it was something called
Dr. Miller.
Dr. Miller probably, Dr. Miller.
Yeah, well, it's back when I first, got involved with this, there's something called Project Lazarus in North Carolina. And so I got really interested in it, and this was years ago. And so I wanted to show and if it's not opioid related, then the overdose reversal drug does not hurt you. And so I started hitting myself with it during my talks every now and then. And I've stopped since doing that, okay? But what I wanted to show them is that if it's not an opioid that's involved, then there's no effect. Right. And so if you find somebody down right now, more likely they're down because of an overdose than they would be to cardiac arrest, at least in the population I deal with. So that's probably not ideal, and I'm not arguing that people need to do that. But I really wanted to show how easy it was, and if it's not an opioid, then there was no effect.
Amazing. I mean, amazing that you did that. I want to go to Suzette, and I want to ask you, in this conversation now, how are people accessing low-cost help for addiction?
That's a great question. So, the great news is that there is low-cost help. Our state, through federal and state funds 7 managing entities across the state of Florida to provide a comprehensive behavioral health system of care. And through that, you can get prevention, treatment, aftercare, case management, care coordination, recovery supports, peer support, a whole host of services that will take the person from the addiction disorder to recovery and beyond. In addition to that, we have recovery community organizations that have peers, but also and are led and run by peers in recovery. My daughter is in recovery 9 years now, and she leads one of those recovery community organizations in Broward County. And they have supports for families. So there's peers for individuals, but there's also peers for families. And something that I didn't have when I was trying to seek help for her, and see, what's available for the parent that is, helping their child and trying to support them through this process as well. So there is low-cost help. Medicaid, Medicare offer programs through their networks and through their health plans, through their managed care health plans. And oftentimes people don't realize that they can speak to their physician and they can speak to their insurance company as well.
Thank you. Thank you again for your transparency, Suzette, and of course, Dr. Lloyd. Dr. Miller, I'd like to talk to you about substance abuse disorder and the cravings involved. And if you can give us some of the science about where cravings come from and how they can be reversed or treated.
Yeah, absolutely. So we talked about it a little bit, you heard a little bit more from Dr. Lloyd. The drugs that we take that are illicit have these really powerful effects on the brain, and you're bathing your entire brain in it, and it's just causing a massive rewiring. And so it literally changes how your brain perceives your environment and responds to it. So that a craving is not just an urge; it's a strong emotional and physiological response because coming from deep inside of your brain due to that rewiring. And there are a lot of things that can trigger it. It can be an internal emotional state, it can be a stressor, it can be things around you, a certain smell that can remind you of using the drug that serves as a trigger, drives that craving. And it's because you have that emotional center in the brain, the amygdala, that's hyperactive, and it's shutting off the front of your brain, which should be responsible for executive function, slow down, make a good decision. It's actually getting gated and shut off so that individuals have a really hard time with the stop and think. And actually encountering a reminder of a drug of abuse can trigger that craving on the order of milliseconds. So we're not talking about a time where someone's consciously perceiving and then making a decision. It's a real reaction.
So continue on with that and tell us about the compound that you've been working on with your team.
Yes, so there's bad news in that the brain is highly plastic, and so drugs are able to change it. That's why I keep talking about the rewiring. But it's also good news in that the brain is highly plastic, and so it's able to be reset. And so there are approaches like cognitive behavioral therapies, which are designed to help individuals sort of stop and register what those triggers are doing before they react. But because of that issue of it happening on an order of milliseconds, that can be really challenging. And so we're developing a medication that taps into that plasticity. And it actually is able to reset the plasticity, specifically in the amygdala, to sort of a pre-drug state. And the idea is to give individuals a sort of a chance to stop and think before they react. So it's something that we're actively developing right now, talking with the FDA to get permission to start early stage clinical trials.
That's really encouraging. And Dr. Lloyd, is there anything you'd like to add to this conversation regarding this work being done?
Well, first of all, I'm sorry for messing my names up. I'm trying to learn you guys as quick as I can. But talking about Dr. Miller. So I want to just take off on one of the things that I love is being able to put things in terms that people can understand. And so, cravings are so fast that they happen, subconsciously. And I explain it using Krispy Kreme donuts because everybody understands Krispy Kreme donuts. And so and I love them. On my deathbed, I told my wife to, stuff them down my ET tube. But, if you think about that, the craving for a Krispy Kreme is, our drive to eat, but the craving for the drug that we're addicted to is multifold more intense, up to 10 times more intense than our cravings are for food when we're hungry. And I think that's what people need to understand. People relapse in general because of cravings, and cravings are lifelong. I've been in recovery over 20 years. I still have cravings every now and then. But as Dr. Miller was explaining, my brain has been rewired through the years, and I now have that delay where I don't act on those impulses. But it takes a long time to do that, and you can't do that in a 14 or 28-day treatment program that I see that being the expected outcome on so many occasions. It's just not reasonable.
Wow. Suzette, there is a stigma, whether it's addiction, mental health, and using medication-assisted treatment. Can you help us understand the impact that that stigma is having?
Yeah, stigma can impact an individual in a way where they lose relationships, they can lose housing and employment, and even in cultures, the consequences can be so adverse that the impact of stigma can be deadly to an individual because it will prevent them from seeking help. They will feel hopeless and helpless. They will feel alone and isolated. And so it's important for us to not only, shatter the thought of stigma and the beliefs of our society on mental health and substance use, but also to do it across cultures. I'm Hispanic, and I can tell you the stigma is so significant in so many cultures. More so than other cultures. And so it's very important to be able to let people know there is help. You can get help, just ask for help.
Dr. Lewis, yes, I'm just coming to you. I know that you, a Black woman of Caribbean descent, talk about stigma within those communities as well.
So similar to our other colleagues in underrepresented communities, what we're experiencing is individuals are being ostracized, eliminated from different communities. In addition to that, there is delay in seeking health care, delay in seeking treatment, or automatically labeling that sister, brother, uncle as drug seeking. They only want money because of this or that, and not necessarily understanding what's happening internally in their brain. So that then delays the opportunity for the person to get treatment. It delays the opportunity for, even if this individual is having now a medical complication, we're saying, oh no, that's just the drugs, and they know how to control it, but they're not trying. So one thing that we're looking at is not only the cultural and religious implications regarding this particular dynamic, but we're also looking at, as providers, how are we reducing the labels of drug-seeking behavior? How are we creating a supportive, individualized type of care where we're looking and understanding overdose treatment, and the psychological, physical implications regarding that? And by the way, cultural. Yes. All of those things together. So it is multifaceted, and we're putting puzzles together. However, what we're learning to understand is we also need to incorporate patience, which is something at times can be delayed, especially in our rapid-paced environment. Yeah. So
that, I mean, we could go on with how culture, religion, all of these things, but I do want to get to a few emails that we've already received. Let's start with James. Dr. Lloyd, I'd like to bring this to you. James is in Pembroke Pines, and he writes, I'm so glad you're talking about fentanyl tonight. I lost a good friend who wasn't an addict, but took a pill at a party we were at, and it wound up being fentanyl and killed him. Are there any obvious signs that something you're offered is fentanyl or has fentanyl in it?
Thanks, Carla. You know, back in the day when this first got started, you know, I could take a look at some of the pressed pills and tell you they were pressed. They didn't look right. They had impurities in them. They didn't look like what comes out of the pharmacy. Those days are gone. I can't tell the difference anymore. So never rely on site. I would never rely on source. You have no idea where it came from, and a lot of times the person who has it probably doesn't have an idea either. The best thing we have to arm ourselves with this is fentanyl test strips. And I'll be interested to see what my colleagues' opinion on fentanyl test strips are, but they can be controversial, and they can also, you know, they also have their downside with, you know, in the drug using community. But I think fentanyl test strips, Carla, are really the best tool that we have, unless my colleagues know of something different.
Thank you so much for that. And Dr. Miller, I want to address Maria's email to you. She's in West Palm Beach, and Maria writes, thank you for playing that video. I feel like I've lost my ability to control my cravings, and it really was bothering me, but I feel like it may be out of my control. What can I do?
It's a tough one right now. It depends largely at this point, unfortunately, on what is sort of which use disorder you're dealing with, because we have options for opioids as we reviewed in that video, but for stimulants, we actually don't have anything currently. In fact, deaths from opioids dropped this past year, finally, but they increased for stimulants like methamphetamine and cocaine. So we've got a big problem. But there are behavioral therapies that are available that can be effective across the classes of drugs, regardless of what you're struggling with. I think one of the things that's proved to be the most effective has been contingency management. And so that's where there's monetary incentives, which might sound a little I don't know, ineffective on the surface, but people do really find them effective. It's sort of that extra motivation or pause to not go out and use when you encounter that craving.
And Suzette, I want to go back to, you know, and then there's the stigma. How do we get people to overcome the stigma associated with treating their addiction?
It's really important that we not just talk amongst our inner circles in behavioral health or in healthcare, but that we also get the word out in our communities, that we share, because you don't know who's sitting next to you. You didn't know that my daughter was in recovery. You don't know, you know, it's across cultures, it's across religions, it's across socioeconomic status, it's across all in our society. And so it's very important that we look at it as more of a conversation. We talked about having naloxone in education and how to use it as a first aid mechanism. This should be also part of that education. This is important for parents, for families, for individuals in our community to be aware and to know and to learn more, so that when an individual does present with an addiction disorder, that they are not afraid to ask for help. Asking for help is the hardest thing that anyone can ask for, and especially when you have ego, when you have pride, and when you add that stigma.
Wow. So now let's turn to the connection between addiction and mental health. Is there a correlation? Check out these stats from 2021 according to the Centers for Disease Control and Prevention, which shows that almost 52 million U.S. adults experienced chronic pain. The study showed that while people living with chronic pain represent about 20% of the population, they make up more than half of adults with clinically significant anxiety and depression symptoms. Dr. Lewis, talk a little bit about the relationship between chronic pain and mental health.
So essentially, it's twofold. They both influence each other. So an individual may have chronic pain and then become very anxious if the pain is not treated properly, or become anxious if a particular medication is not as effective. In addition to that, individuals can experience depression as a result of the whole pain cycle, but we also have to address certain illnesses such as fibromyalgia. There is a connection between that and depression. So what we need to do is effectively address mental health, but not only through a pharmacological aspect, but also through therapy, behavioral aspects, or other components of non-pharmacological methods, visualization, and also we need to bring back in what brings that person joy. Because we essentially, with pain, anxiety, and depression, we need to focus on quality of life for that individual. So those are things as healthcare providers, we need to look as a holistic perspective, not just only looking at, okay, we gave this person a tablet, a patch, or we told them, visualize you're on the beach. That might not be effective for all of our patients. So really paint each brush individually and each patient individually.
Dr. Lloyd, I want to come back to you. Pain is just one factor. I wonder if you could talk a little bit about how other mental health issues play a role.
Well, Carla, the biggest reason that I see patients relapsing after a period of extended abstinence is untreated mental health issues. Anxiety, depression, and the big one in the population that I see most of the time is post-traumatic stress disorder. And so, we have to be aggressive at treating these underlying mental illnesses. In my own case, my substance use started with self-treatment of anxiety and depression. And the first time I took an opioid, I felt like I'd found a cure for depression. And I had some psychiatrist jump up in a talk I gave one time and said, opioids are not a treatment for depression. Well, I know that. That wasn't my point. My point was that it gave me relief of those symptoms. And so, I hadn't had that in a really long time. And also I've done some research since then. So opioids have been used to treat depression since the time of Hippocrates. So I can't wait to see that psychiatrist again one of these days. But I think that it's one of the biggest reasons that I see that people, continue to use, because we haven't addressed those underlying mental health issues that are so vital to long-term sustained recovery.
Another factor in mental health and addiction could be related to undiagnosed autism in teens and young adults, and the increased potential for mental health issues as these younger people grow up. We recently sat down with Sylvia Quintana, the CEO of the Broward County Behavioral Health Coalition, and she talked about the alarming numbers of teens with previously undiagnosed cases of autism.
What we're finding is that, especially the autism spectrum part of it, people kind of pretend that things are not really happening, especially when there's mild autism, and so then things exacerbate and become problematic. And this is where the emotional disorders begin to appear, the anxiety begins to appear, the difficulties with social interactions begin to exacerbate. Nowadays, people try to medicate their dysfunctions, especially teenagers and so forth. They don't feel comfortable with themselves. They don't feel comfortable with others. So another way of addressing not feeling well or isolated and so forth many times is the start of using drugs, right? They medicate their feelings of inadequacy or isolation or frustration. And that could be another mechanism to begin using drugs as a way of dealing with autism spectrum symptoms.
Suzette, your thoughts on undiagnosed autism and the topic we're talking about today?
Sure. So undiagnosed autism, you have, as Sylvia Quintana stated in the video, is you have individuals that have difficulty with social situations, socialization, reading social cues, and then you also have sensory issues coupled with that. And all of that can create a state of anxiety, depression, and that can deteriorate as they can see that they're not relating to their peers the older that they get and they enter into those teenage years. And then from there, you have the mental illness, and so then they start to self-medicate, and they find that the self-medication helps them feel better, as Dr. Lloyd had stated earlier. And so now you have a trifecta of someone who's undiagnosed with autism spectrum disorder, undiagnosed mental illness, and undiagnosed substance use disorder.
Dr. Miller, talking about the undiagnosed autism, what about mental health, and then thinking about those that are incarcerated and dealing with the undiagnosed autism and the addiction?
That's an interesting question, and I'll be honest, it's not one that I have a whole lot of experience to offer, unfortunately.
Or Dr. Lloyd, jump in if you want to add on.
Well, I mean, Carla, I'm so glad we got to this topic, because until we address this issue in our carceral facilities, we're not going to move the needle. And I work in those, not just peripherally. I've been in them. I've been in them here in West Virginia, thanks to some folks who really care. And I see it a lot. Autism is kind of a new one for me in learning what the implications of that are. But Dr. Sylvia Quintana, her explanation there, I absolutely love, because it's about, these feelings of uncomfortableness. And then all of a sudden you find yourself with a chemical or something in your hand that can make you feel comfortable in your own skin. And that's really what I see when I'm dealing with patients on the autism spectrum. And I see it all the time in carceral facilities. And let's face it, we don't do a good job about addressing mental health issues in our carceral facilities, nor do we do a good job of addressing our substance use issues in there. And then we turn people loose, because 95% of the people who are incarcerated will walk the street again. And I don't know about you guys, but I would rather have them healthy than sick. And we don't address it. And so it's our biggest missed opportunity in the United States right now.
Thanks again, Dr. Lloyd. We have another email, this time from Lisa in South Miami. And she writes, I just watched your segment on the tie between undiagnosed autism and drug addiction, and can say it does happen. We saw signs in my teenager that we honestly hoped and prayed that was nothing. I wish we treated them at the time. My son is now in rehab, but thankfully he's alive. Just wanted to share so other families won't make the same mistake. Thank you so much, Lisa. That is really great news. Suzette, we are so glad to hear that Lisa's son is on the up and up. And the undiagnosed autism and drug addiction, we can say that it does happen. And did you see the signs in your teenager?
So I did see some of the signs. My daughter doesn't have an autism disorder. I do have a son who's mildly autistic, though, and I did see some early on, when preteen, see some anxiety in him. I did get him help. That's the good news, and he's now very well integrated with his peers, and he's getting ready to prepare for college. But going back to that with my daughter, I did see some signs of her mental health deteriorating as she was in her mid-teens and later years. As it relates to autism, it's very important to pay attention to the signs, and I do agree with Dr. Lloyd that it is a missed opportunity for us.
And how can caregivers get support?
So, good news is that there is more and more support. There's growing support, especially here in South Florida. For instance, there's FAU has a center for autism disorder. There is a lot of providers out in the community that are starting to specialize in those areas. It's also important for not just the treatment of the mental health and the substance use, but also the treatment of the autism disorder in terms of learning to read social cues and understanding them so they can start to feel more comfortable, understanding how to deal with their sensory issues as well, to help them, that should be part of their treatment plan and be integrated into their treatment plan so that they can really have a more holistic approach. I do agree with you in terms of that holistic approach to their treatment and recovery.
Dr. Lloyd, I see you shaking your head. Let us know what you're thinking.
Well, first of all, I love my peers, so thank you. It is a comprehensive approach, and I'd be interested to see what my peers think about this. But we have this idea that we can somehow separate addiction out from all this stuff and treat it in a vacuum, and I'm telling you that won't work. I've never seen it work. And it doesn't work over the long term. So our approach does need to be comprehensive in taking into account, underlying autism that may or may not be diagnosed, underlying mental health issues that may or may not and are often not diagnosed. So I couldn't agree more with the approach. And I think that we need to get away from this idea that we send somebody away for X amount of time and teach them how to not use drugs. Well, that's not how this works. And even medication-assisted treatment isn't like that. I mean, it's a very valuable tool. It saves lives, and I think we're all in support of it, although we still have to battle it, in the outside world, the stigma around it. But at the same time, it needs to be a comprehensive approach around that, because we need to be talking about, housing situation. We need to talk about access to job, IDs. You got a felony on your record, what that means for trying to secure a future going forward. So the approach has to be comprehensive, and we need to be talking about a recovery-oriented system of care that takes all of these factors into account. And I'm going to say something really bad now, which is we need to be looking at insurance reimbursement models that allows for this treatment process to happen instead of letting kids die.
Yes, 100%.
Dr. Lewis, I want to come to you as you have young children.
Yes.
And other families think about their kids being labeled. But how can getting early help the families?
Definitely, that's a great question. So I have 3 young children, all below the age of 13. And essentially, as parents, there are times you may feel handicapped, or there are times you may feel, you're experiencing this situation by yourself. Right. However, there are resources available if you speak up. So the key aspect is speak up and ask questions and inquire regarding situations where children are behaving in a particular way. Were there any triggers? Were there any other examples where the child felt anxious? Because labeling is an issue. It's our societal issue. It's a global issue. Yes. And what we need to do as parents is to collaborate with healthcare professionals, collaborate with learning specialists at various schools, as well as the teacher. The teacher may say, you know what, during this particular activity, your child becomes more anxious or tries to behave in a particular way that does not follow the school rules. And how can we work as a team? Not pointing fingers and labeling, but work as a team to create a strategic plan to prevent some complications that could happen later on in their life.
That does change the trajectory, because through collaboration with my son's school, I was able to get him the help that he needed through social interventions.
Wow. Yeah. Thank you.
So I don't have that perfect segue,
please.
But there's one thing that we've been talking about quite a bit is medication-assisted treatment and stigma. And I think there's a real push to change the way that we describe it because of that stigma. So the term medication-assisted treatment suggests that a medication isn't itself a treatment, but it is. And so there's a real push to describe it as a medication for opioid use disorder, for instance. And I think when you're talking about taking a holistic approach and trying to show someone that it's okay to seek treatment, I think even just that small change can make a really big difference.
Correct.
That's true, very
Definitely.
true.
Dr. Lloyd, I'd like to talk with you again. You've made some changes during your time in office of drug control policy in West Virginia. Please tell us what's working there and what other states can learn from your state's experience.
2 big ones here, and I'd like to tell you I did them, but I didn't. There are a lot of really great people in this state that I've been in awe of in my time here. The biggest change that I see that I would encourage other states to look at is treat your carceral population. First of all, you're violating the law if you don't. You're violating the Americans with Disabilities Act, and you're violating the 8th Amendment of the Constitution of the United States. But people don't seem to have a problem with that sometimes. So that's the biggest one that I see here. We have 10,000 people incarcerated in the state of West Virginia, And we have about 4,780 of them that are actively being treated with medications to treat opioid use disorder behind bars. And so that is a big one. The other one is starting to utilize analytics and big data, believe it or not. And that's coming from a guy who can barely operate his phone. But we have quick response teams in our state that are all over our state. And one of the things that we can do, we know where our feeder cities are. For us, it's DC, DC, Baltimore, then Pittsburgh, Columbus, Ohio. We know that when drug shipments hit those areas and they start seeing overdoses, and because of the data that we track, we know almost down to the hour and in which streets we're going to start seeing this in West Virginia. And so how does that help us? We can deploy those quick response teams even before the drugs hit our streets, and teams armed with overdose reversal drugs to get to our patients before they die. And I think that these two models are replicatable in every city every city and every state in the United States. And I applaud the folks here in West Virginia who piloted those and now have them basically part of our milieu and a recovery-oriented system of care.
Indeed. Thank you so much for sharing that. And Dr. Lewis, your thoughts on the importance of finding a resolution for the addiction epidemic?
I think there is a way that we can find a solution. What it will entail is a lot of coaxing, a lot of demystifying stigma, as well as the same way that it took some time to infuse the clean IV needles, and we went through that whole process of saying they should not be IV injecting. However, let's at least let it be clean. Those are other aspects that we need to focus on: prevention and early activation, compared to just only let's address it once they develop an issue. We need that early activation signal to say, okay, these are the areas, we have the data to show it's these zip codes, these areas, these times a day, and also getting through the element of understanding that this can start very young. So we shouldn't wait until teenagers. We should start this in middle school, elementary school, and have these conversations, because it took some time to discuss sexual activity in schools, but now we really need to hone in on opioid prevention in schools, because children are trying to find a way to get out of the situation, whether it's from peer pressure or it is just from their own experiences. So that's one of the
great sentiment, Dr. Lewis. Suzette, on that note, any other free resources that are there for people to use?
Absolutely. So, I talked about the publicly funded comprehensive behavioral health system of care by the managing entities. Those are all free resources to uninsured and underinsured individuals. There's also free information and referral through 211. There's the Florida Lifeline for crisis counselors 24/7, which is 988, So, and of course, if someone's in an emergency situation, we want them to dial 911. But in addition to that, we have free Naloxone throughout our state. And, you can navigate to isavefl.com and look for where Naloxone is distributed near your residence, your neighborhood, so that you can access it and have it readily available. So there's lots of free resources available in our community, from services like treatment and recovery, but also things like Naloxone, and you can even get training. And like we've talked about today, it is really very easy.
And Dr. Miller, your final thoughts on the research that you're doing and how we might be having a different discussion maybe next year?
I certainly hope that that's the case. We'll see. As I mentioned earlier, there's nothing available currently for people that are struggling with stimulant use. We've spent a lot of time and energy, for good reason, on opioids, but unfortunately stimulants are coming in behind that. And so I'm really hopeful that the medication we're developing is able to help them. And we've actually been identifying ways to extend it to benefit in opioids and alcohol use as well.
Dr. Lloyd, you got 1 minute to wrap it up for us. What would you like our audience to be left with, considering your professional and your personal experiences?
Well, Carla, our overdose numbers are going down across the United States at levels that I didn't know if I would ever see in my career, and I'm extremely happy about that. But there's two populations where they're not only not going down, they're not plateaued, they're actually rising. and that's in our Black and brown communities. And I'm going to I'll paraphrase Dr. King. Dr. King says, as long as one group is being discriminated against and doesn't have rights, none of us do. And I take that same approach when it comes to the opioid crisis, particularly with heroin and fentanyl. Our Black and brown communities still have overdose rates that are on the increase, and we need to figure out the reasons for that. I think we know some of them, and we need to do some of the things that Dr. Lewis was alluding to earlier. So that's my parting shot.
Dr. Lewis, 15 seconds, your last thought.
Just know that individuals that are experiencing this addiction may not look like what you think they may look like. Their age may be a variety of ages, and just please be open and receptive when somebody expresses concern.
What a panel, and just thank you to all of you for your insight. Thank you for joining us on what has been a great discussion on an important topic. And remember, there is no shame in getting help. If you or someone you know needs help in the battle against opioid addiction, please reach out and get help today. I'm Carla Hill. We'll see you next time, and take care.
Thank you to the Eunice Joyce Gardner Charitable Foundation for its leadership support of the Health Channel.